enjoyed the workshops earlier this afternoon. I had a chance to pop into all of them and was really impressed with the information being shared, and definitely found it to be engaging. Can't believe that we are almost at the end of our two-day event. Want to thank you so much for your participation and engagement throughout this event. I know that I can speak for myself. I am feeling invigorated and inspired from all of the speakers and work that we have heard about to take action. So I've been looking forward to this closing keynote. Very excited to hear from Dr. Brian Smedley. I had the opportunity to meet Dr. Smedley almost 10 years ago when I was a health policy fellow with the Satcher Health Leadership Institute, and have just admired and referenced his work in so many different ways over that time. So very, very happy to have him here to provide the closing keynote. Dr. Brian Smedley is among the inaugural class of equity scholars at the Urban Institute, where he conducts research and policy analysis to address structural and institutional forms of racism that impact the health and well-being of people of color. Formerly, Dr. Smedley was chief of psychology in the public interest at the American Psychological Association, where he led APA's efforts to apply the science and practice of psychology to the fundamental problems of human welfare and social justice. A national thought leader in the field of health equity, Dr. Smedley got his start in Washington, D.C. as an APA Congressional Science Fellow, and subsequently served at APA as Director of Public Interest Policy. Most recently, he was co-founder and executive director of the National Collaborative for Health Equity, a project that connects research, policy analysis, and communications with on-the-ground activism to advance health equity. He was also co-director of the Robert Wood Johnson Foundation Culture of Health Leadership National Program Center. From 2008 to 2014, Dr. Smedley was vice president and director of the Health Policy Institute of the Joint Center for Political and Economic Studies in Washington, D.C., a research and policy organization focused on addressing the needs of communities of color. Previously, Dr. Smedley was research director and co-founder of the communications, research, and policy organization, The Opportunity Agenda, which seeks to build the national will to expand opportunity for all. Prior to helping launch the Opportunity Agenda, Dr. Smedley was a senior program officer at the Institute of Medicine, where he served as study director for the IOM reports in the nation's compelling interest, ensuring diversity in the healthcare workforce, and unequal treatment, confronting racial and ethnic disparities in healthcare, among other reports on diversity in the health professions and minority health research and policy. Among his awards and distinctions, in 2013, Dr. Smedley received the American Public Health Association's Cornelia Award for Social Activism. In 2009, he received the Congressional Black Caucus Congressional Leadership and Advocacy Award. In 2005, he received a presidential citation from the APA. In 2004, he was honored by the Rainbow and Push Coalition as a Health Trailblazer Award winner. And in 2002, he was awarded the Congressional Black Caucus Healthcare Hero Award. Dr. Smedley received his PhD in clinical psychology from UCLA and a degree in psychology and social relations from Harvard. Welcome, Dr. Smedley. We can't wait to hear from you.
Thank you so much, Megan. I'm so grateful for this opportunity to speak at this conference. It looks like it's been an amazing event. And I also want to lift up and congratulate the National Center for Primary Care at the Morehouse School of Medicine, which is celebrating its 25th anniversary. And I think for many of us who are concerned about addressing the health needs of communities of color, the National Center has been a true beacon of light in terms of how you engage with community, the research that you're conducting, certainly innovations in clinical service delivery, and ensuring that there are models and ways of innovative healthcare for populations that have been so desperately needing care. So it is a true honor to speak to the National Center for Primary Care on this wonderful anniversary. I want to just dive right in and talk about racism and its impacts on health. And I don't need to educate this audience about the pervasiveness and the depth of racism operating in this country and the toll it's taken, not only on Black lives, but I would argue the nation as a whole. because racism, as Dr. Kamara Jones has argued, unfairly taps the potential of the whole society, therefore hurting all of us. So it's been encouraging to see that there is a dialogue, a robust dialogue happening about how racism is in fact a public health crisis. It's been gratifying to see many local jurisdictions, states, and indeed our own federal Centers for Disease Control and Prevention declaring that racism is in fact a public health crisis. It's therefore imperative that we understand racism, how it operates, and that we are actively working to dismantle racism in all its forms. And so in the spirit of this conference, we are all looking to what is it that we can each do. And so I hope to lift up strategies that we can each undertake in our work, in our communities, to begin to dismantle racism and to ensure that the conversations that we're having about racism are urgent and that we are all prepared to put our shoulders to the wheel to do this work. We know that racism operates at many levels. Dr. Kamara Jones has led some important scholarship defining racism as a system that unfairly assigns value and allocates opportunity based on perceived racial group affiliation. That definition has been so important for public health and for many other sectors, but I want to go further here to be clear about what we mean by systemic racism. Again, it's important that this conversation is happening in many sectors, many quarters across the country, but too many fail to understand the pervasiveness of racism and the fact that racism is not solely dependent on individual attitudes. Of course, individual attitudes remain problematic. Arguably, we are seeing naked racism in its many forms expressed in our politics, in our economy, in our social structures. Arguably, there is a sizable segment of the American population for whom racism is not a bad thing, and indeed, that is the status quo that many are most comfortable with. And so those reflect individual racist attitudes. But we've got to be clear that when it comes to health, structural and institutional forms of racism are deeply harmful and need to be among the issues that we're talking about. Of course, when I'm talking about structural forms of racism, I'm talking about a system of social structures, laws, policies, cultural narratives that produce cumulative, durable race-based inequality. And so obviously, if drawing from the scholarship of Dr. David Williams and many others, we know that residential segregation is foundational to understanding racialized inequality in this country. We know that for most of our history, people of color have not been allowed to live where they might choose to live, and to further that harm, government at all levels and the private sector have conspired throughout most of our history to constrain economic development, indeed to choke off economic development in communities of color, highly segregated communities, through things like redlining. And of course, the impact of those policies from an economic and health standpoint persist. Other structural forms of racism include school segregation, separate and unequal schools. We know that schools that are serving primarily kids of color lack the resources necessary to help kids succeed, lacking in teachers credentialed to teach in the subjects that they're teaching in, poor facilities, outdated textbooks, et cetera. And we also have healthcare segregation, which I'm going to talk a little bit more about this afternoon, again, as a fundamental cause of racial inequality. We also have, of course, institutional racism, policies, practices, and procedures of institutions that have a disproportionate and negative impact on people of color and access to goods, services, resources, and opportunities. None of these policies explicitly states that these institutions seek to discriminate. In fact, these policies are almost always neutral with respect to race, but the harm that they cause is incalculable. And I'm talking about things like inequitable law enforcement. We all are aware of how aggressive law enforcement is in communities of color, with policies like stop and frisk that have put people of color, particularly Black and brown young men, in harm's way. Institutional racism in criminal justice systems is one of the major drivers of the disproportionate confinement of people of color and disproportionate representation in criminal justice systems. So again, structural and institutional forms of racism are not necessarily dependent on individual attitudes alone, but rather are so deeply baked in that we rarely even stop to consider how pervasive they are, even beyond individual attitudes. And to these forms of racism, I would add internalized forms of racism, the acceptance by marginalized populations of negative societal stereotypes about themselves, beliefs which can lead to the perception of oneself as worthless and powerless. So we've got to tackle racism at all of these levels if we're going to be successful. Even if we were to wave a magic wand today and eradicate racism from the minds of tens of millions of Americans, and I would argue that that's the number that we're dealing with, we would still have structural and institutional and internalized forms of racism until we are intentional about dismantling them. It's also true that these many forms of racism often interact in ways that mutually reinforce each other. For example, at least some of the healthcare quality disparities in the United States are due to physician biases, both explicit and implicit. Implicit biases, of course, are those biases and stereotypes that are likely to be activated in settings characterized by time pressure, resource constraints, and cognitive complexity. These kinds of characteristics force providers in some cases to fall back on stereotypes and biases, some of which they may not even be consciously aware of because of the need to fill in missing information. It's also true that the very systems characterized by the most time pressure, the greatest resource constraints, and the greatest cognitive complexity for providers are our safety net institutions, the very systems where people of color and low-income people are disproportionately seen for their treatment. So we need to be clear that the way that we've set up our healthcare systems also can set up biases and promote biases among providers. In turn, pressures on safety net systems reflect structural issues, such as the view in the United States that healthcare is a market commodity. That view dictates that the best healthcare and the most care will go to those who can afford it. And that begins to set up a structural inequality between people of color and wealthier white populations. This market-based approach also contributes to the geographic maldistribution of our healthcare resources. Communities that are sickest and poorest have the least access to needed healthcare services in their communities. And the services that they do access, in some cases, these are the very systems that are struggling to provide high quality care because of a lack of resources for those systems. 20 years ago, I had the great honor of serving as study director for the Institute of Medicine report called Unequal Treatment. Institute of Medicine, of course, today is the National Academy of Medicine. But when this report was released in March of 2002, it lit a firestorm. Healthcare providers and policymakers were just aghast at the key finding, which was that racial and ethnic disparities in the quality of healthcare persist even after we control for access-related factors, such as whether or not people have health insurance, or whether or not they have an income that allows them to pay for out-of-pocket costs. This was the charge to the committee from Congress. Are these disparities in the quality of care consistent even after we control for access-related factors? Not only did this committee conclude that these inequities were pervasive across a range of clinical services and disease areas, but also that many factors contribute to these disparities, including biases on the part of clinicians. And so that really, we had hoped, was a wake-up call, not only for the healthcare professions, but also our policymakers and our regulators who set the context for healthcare delivery in the United States, and payers and many other stakeholders that are engaged in this work. Are we making progress in the fight to eliminate healthcare disparities? I'm deeply discouraged and disappointed to say that we have made little progress. And you don't have to just listen to me. The 2021 Agency for Healthcare Research and Quality National Healthcare Disparities and Quality Report finds that since 2000, disparities have narrowed for only about 8% of measures for American Indian and Alaska Native populations, 2% of measures for Asian American populations, 3% of measures for Black populations, 4% of measures for Hispanic populations, and 10% of measures for Native Hawaiian Pacific Islander populations. It's fair to say that 20 years ago, we thought that by presenting the evidence of the pervasiveness of healthcare disparities and a set of solutions to begin to chip away at it, that we would generate the political will and the outrage necessary to begin to change these conditions. These data suggest that even in the face of the evidence, we did not have the political will as a nation to tackle these inequities. AHRQ's 2021 healthcare report also shows that for a range of populations of color, that we are essentially in a stagnant position with respect to improving healthcare quality. This slide shows the number and percentage of quality measures for populations of color relative to the white population for the most recent data years that were collected. And you'll see that for American Indians and Alaska Natives, African Americans, and the Latinx population, on about 40% of the measures, we continue to see that people of color receive a lower quality of care. That's in the red shading on this bar. For about half of these measures, it's about the same. And for a very, very small fraction of measures, we see that quality of care is improving for populations of color relative to the white population. But it's safe to say that there has been a negative inertia, a lack of progress toward addressing these inequities. When we focus in on the African American population relative to white populations, you can see again that very little is changing in terms of improving the quality of care. And on a number of measures, we see that again, African Americans are experiencing a worse quality of care on a significant number of metrics that AHRQ tracks, 152 measures in fact. So it's safe to say that we have made little progress despite decades of research, decades of awareness of the persistence of the problem. Sadly, there are many examples of persistent healthcare inequity. People of color are less likely than whites to receive even routine medical procedures and preventive care. Black patients are treated less for pain than white patients. There are many examples of this kind of research. Patients with long bone fractures, Black and white patients with equivalent long bone fractures and presumably equivalent levels of pain as a result, African Americans are treated less aggressively for pain. Sickle cell patients have to wait longer in emergency rooms to get pain medication than white patients who have similar levels of pain. Black patients are less likely than whites to receive kidney transplants. Doctors are almost twice as likely to refer white patients to specialists than they are to refer Black patients. And Black and Latinx individuals are less likely to receive appropriate cardiac medication or to undergo cardiac bypass surgery than whites. This is just the tip of the iceberg. We know that across a range of clinical services and disease areas, literally from A to Z, you see a persistent pattern, particularly lower quality of care for African Americans relative to whites. Now, the problem of healthcare inequities is complex. There are many factors associated with healthcare inequity. It's impossible to boil it down to one or two single causes, but several factors appear to be most robust, most salient when we look at the literature. In my view, first among them is separate and inequitable healthcare systems, the persistence of medical apartheid due to residential segregation, the maldistribution of healthcare resources. Again, if healthcare is a market commodity, naturally you would expect that more and the best quality care is going to be cited in the wealthiest and healthiest communities, rather than creating payment systems that equalize payments for all populations and incentivize providers equally, no matter where a patient lives or what their presenting condition or race or ethnicity is. Other policies of health systems and health plans, such as limited provider networks, can also constrain opportunities for people of color to find and access appropriate care. Second, we continue to have tiered health insurance and differences in provider reimbursement. This is closely related to the problem of separate and inequitable healthcare systems, but the simple reality is that people of color are disproportionately concentrated in lower tier health insurance products, even among those who are privately insured. And then when you look at the Medicaid population, with a heavy concentration of people of color, low reimbursement rates in the Medicaid program clearly limit access to care and limit the quality of care that patients receive. We need to be honest about that. Third, clinician biases, stereotypes, and prejudice continue to infect the clinical encounter, and I'm going to provide some examples of this shortly. Fourth, we see increasing use of race-based clinical decision supports and algorithms and artificial intelligence that has great potential to widen healthcare inequities rather than to narrow those inequities. I'm going to provide some examples of that shortly. Then finally, we see a persistent lack of diversity among healthcare professionals. There is evidence emerging that providers of color provide a higher quality of care to patients where there is racial concordance. And I want to cite some of that research for us. It's a new body of research, and more research needs to be done. But clearly, the lack of diversity among our providers is among those factors that we urgently need to tackle. I want to address these 5 different factors separately to dive into them a little bit more deeply and to talk about what we can do to address them. First, medical apartheid, separate and unequal care. All of you are familiar with this phenomenon. This is not new. It is as old as our medical systems in this country themselves. My colleagues at the Urban Institute have done some research on the persistence of inequitable care across healthcare systems, also within healthcare systems. So, for example, my colleagues conducted a study investigating differences in Black and white patient safety measures using hospital discharge records in 27 states. This team found that Black patients experienced higher rates of adverse safety events on over 50% of the patient safety measures. Black patients were significantly less likely to be admitted to hospitals classified as high-quality hospitals relative to white patients. The same research team found that Black patients experience higher rates of hospital-acquired illnesses or injuries related to surgical procedures relative to white patients, even in the same hospital and with the same forms of health insurance. So this research points to both the structural inequity of quality gaps across our healthcare systems, as well as inequities within our healthcare system, showing the complexity of the problem and illustrating why our interventions need to be comprehensive. We can't just simply address inequities within healthcare systems alone, but across all of our healthcare systems. We continue to see tiered health insurance. People of color, as I mentioned, remain disproportionately and underinsured despite the Affordable Care Act. Now, let's be clear, the Affordable Care Act has done wonders to improve access to health insurance and subsequently access to health care for many, many millions of Americans, including people of color. But the problem of tiered health insurance persists. Our study committee for the Unequal Treatment Report wrote 20 years ago that medical care financing arrangements should discourage fragmentation of healthcare provision into separate tiers of providers who adhere to different standards of care and disproportionately serve separate racial and ethnic segments of the American society. This report urged that Medicaid and other government programs that mandate enrollment of Medicaid enrollees in have access to the same health plan products, serving substantial proportions of the privately insured population. And clearly that has not happened. Third, let me turn to the problem of racial bias. I am a psychologist. I am grateful that my discipline has spent considerable time over many decades studying the issue of bias, trying to understand how do biases originate. We know that some biases are explicit, that is, that we are consciously aware of them, but there are many other biases that we are not consciously aware of. And the key takeaway here is that we are all vulnerable. Humans are cognitive misers. We like to limit the amount of effort that we expend trying to understand our world, and we rely on mental shortcuts. That's just the nature of the human brain and the way it works. Social categorization makes people feel that they understand the world because when we categorize a person into a group, we feel like we can predict their behavior, understand their proclivities, likes, dislikes. So we are unfairly lumping people into groups and assuming that we understand who these human beings are based on their group category. And in particular, in the United States, a person's race is an especially powerful determinant of how we socially categorize others, and consequently, how we perceive those in our in-group and those in our out-group, because race has been one of the most socially significant ways to classify people throughout U.S. history. And this falls back on the cultural narratives and belief systems in the United States that have long been built around notions of white supremacy and Black inferiority. And until we are honest about that pervasive cultural milieu, it is unlikely that we're going to be able to prevent others from developing biases. Implicit racial biases are those attitudes and beliefs that are automatically and quickly activated when people are exposed to members of a social group different from theirs and for which they've already developed a bias. Implicit attitudes and stereotypes represent feelings and thoughts about a target group that, again, are embedded in our cultural norms and belief systems. As people become socialized into our culture, these feelings and beliefs become so ingrained that they automatically produce associations between individuals and the groups that we assume that they belong to. These stereotypes are so well learned that people are often unaware that they are making them, even among highly educated, egalitarian people. We know that racial biases persist and are prevalent among healthcare providers. One systematic review of 15 studies measuring implicit bias and health outcomes confirmed that healthcare professionals hold the same level of implicit bias against Black, Latinx, and dark-skinned people as the general population. And I should note that the implicit association test, which folks can take online, has now gathered data from hundreds of thousands of individuals in the United States and abroad, finding high levels, 60, 70% prevalence of a pro-white bias. It should be noted that even half of people of color harbor pro-white biases in the United States. Understandable, but a horrible thought. Understandable because of our culture and our belief systems, the way our society is structured, and the prevalence of white supremacist ideology, but clearly deeply disturbing. And again, in my view, points to the importance of acknowledging and addressing internalized forms of racism. Another systematic review of 37 studies confirmed substantial evidence of a pro-white or light-skinned, anti-Black, Hispanic, or American Indian or dark-skinned bias among a variety of healthcare professionals in a variety of settings and levels of training. We know that these biases make a difference in the way physicians think and behave. One study found that over 70% of white medical students and residents believe that there are biological differences in pain perception between Blacks and whites. Recall the research I've just cited showing that African-American patients are less likely to be treated for pain that a white patient may be experiencing. So we need to get at the roots of these belief systems that our future healthcare workforce harbors. Physicians' implicit biases also predicts the degree of aggressiveness to which they will treat medical conditions. Alex Green and his colleagues presented a series of patient vignettes with patients who clearly needed cardiac procedures, but they found that physicians that had higher levels of implicit bias, anti-Black implicit bias, were more reluctant to recommend aggressive treatment for African Americans displaying symptoms of cardiac disease. In contrast, those white patients were much more likely to be treated aggressively, and particularly by those providers that harbored high levels of pro-white bias. So these biases make a difference in the clinical encounter. There's also recent evidence that people of color, particularly African Americans, are much more likely than white patients to have negative patient descriptors in their medical records. One study by Sun and colleagues found that with a sample of over 40,000 history and physical notes from 18,459 patients, that sentences containing negative descriptors were much more common for African American patients, 2.5 times more likely to be found for Black patients than white patients in their medical records. And the authors concluded that the findings raised concerns about stigmatizing language in the electronic health record and its potential to exacerbate racial and ethnic healthcare disparities. This study was just published this year. Hard to believe that these biases persist to this day. Other studies find that, importantly, physician and patient racial concordance can make a difference. Here's a recent study from Greenwood and colleagues finding that among nearly 2 million hospital births in the state of Florida, when physician racial concordance is for African-American infants is the same, mortality rates are halved. And many of us Many of you know, of course, that Black newborns die at a rate 3 times that of white newborns. This finding suggests that increasing options for patients to achieve racial concordance with their provider may help improve health outcomes, and certainly in the neonatal context. More recently, there are great concerns about the use of clinical decision support tools, the use of artificial intelligence, and race-based algorithms. Now, certainly, artificial intelligence appears to be here to stay. Clinical decision supports are certainly urgently needed in many cases, but they have great potential to cause more harm than good. This report by the House Ways and Means Committee Majority Staff Report in 2020 found that clinical decision support tools can help in some cases to address racial health disparities, but their potential to advance equity is complicated by the reality that the methods and assumptions used in the algorithms at the core of CDSTs may themselves import biases, leading the New England Journal of Medicine to conclude in 2020 that many of these race-adjusted algorithms guide decisions in ways that may direct more attention or resources to white patients than to people of color. So it's important to note here that, of course, these algorithms are based on the fact that in many cases, people of color are coming into health systems sicker than white patients. We need to acknowledge that patients of color are coming in sicker because of racism. Differences in patient health and well-being are most likely due to the effects of racism and other determinants of health, not biological effects of one race versus another. As the sociologist Troy Duster used to argue, the relationship between race and health is biological in consequence, not in origin. In other words, it's the lived experience of being a people of color in the United States that is hazardous to one's health, not something intrinsic to race itself. With my psychology colleagues, Drs. Lou Pinner, Jack DeVideo, now Hajawara, we are shortly about to publish a book called Unequal Health, Anti-Black Racism and the Threat to American Health, where we identify a number of areas where we have opportunities to address and dismantle forms of racism in our healthcare systems and in the determinants of health. We argue for structural equity, that is to promote universal coverage with comprehensive benefits and equitable reimbursement. In my view, we can only achieve this through a Medicare for all or single payer type system. This would equalize payment for services across health systems, across patients, across communities in ways that do not exist today. So in this way, it would address the maldistribution of healthcare resources and some of the medical segregation that we see, but it will not by itself completely eliminate inequities. That's because all of the other forms of structural and institutional racism that we see in our society are not solved by Medicare for all. Medicare for all simply provides us with the tools to begin to address the downstream consequences of racism in the patient population. We call for institutional equity, providing resources for hospital and health systems according to need. That's the very definition of equity. This means that our safety net institutions, our systems serving disproportionately low-income patients and patients of color should receive more resources to be able to catch up to other health systems and to be able to have the resources and services that are necessary to provide high-quality care, again, for a patient population that's often sicker coming into the system to begin with than white patients. And institutional inequity requires public reporting of healthcare quality and access data by patient demographic factors. To me, this is the best form of accountability that we as a community, as a nation can have for advancing equity in our healthcare systems. If we don't measure and monitor the thing that we're trying to change, we will never change it. In my view, we need complete and comprehensive data collection and to publicly report those data along quality and access measures so that our patients, our communities can see where these inequities are occurring. You can bet that when the light of day hits these data, health systems will take more significant strides to eliminate these health inequities than when these data are hidden from the public. We call for efforts to improve clinical equity, stopping the inappropriate use of patient race in medical diagnosis and treatments. One of the biggest reasons today why Black people are undertreated for kidney disease is that too many providers are using race-based algorithms, assigning a different level of severity for African-American patients with kidney disease than white patients, meaning that white patients get on kidney transplant lists a lot quicker and more often than African-American patients. That's an injustice that simply shouldn't exist. Other forms of clinical equity, including addressing race and difference in the clinical encounter. We've now got decades of experience with efforts to train our healthcare providers to be better able to deal with diverse patient populations. Unfortunately, what we've learned is that one-shot training on anti-bias, for example, does not do the trick, and in fact can cause more harm than good, because people assume that with one or two trainings, they are fully culturally competent and prepared to address the complex needs of diverse patient populations. The reality is, for our healthcare providers, learning to be unbiased, to be anti-biased takes lifelong learning and a commitment, dedication to ensuring that we unearth the biases that are within all of us, particularly if you've been socialized and raised in the US context as well as other Western nations. Finally, we need educational equity. Increasing the share of Black and other people in healthcare professions is critically important, but of course, educational equity is also a health-enhancing intervention in itself. We know that the single biggest predictor of your health status is your educational attainment. And again, because of the fact that kids of color are disproportionately concentrated in lower performing educational systems, under-resourced schools that are neglected and are poorly prepared to help young people go into higher education. We've got to change that equation. That starts with things like looking at funding formulas. 90% of our educational dollars come from local tax sources. And so if you're from a place like Detroit, as I am, where the local tax base is severely depressed because of population loss, because of white flight, because of segregation, that means that that jurisdiction does not have the resources to help kids succeed. We need to change those educational funding formulas and fight for educational equity. On the point of diversity among our healthcare workforce, you are all aware that people of color are disproportionately are underrepresented among our healthcare workforce, particularly among physicians, as you can see from these data from the 2021 ARC report. We need to change this equation, and it starts by working toward educational equity. But there are other things that we can also do, aside from addressing the supply of talented young people prepared to come into health professions careers. We need to work with our health professions educational institutions to change things like their admissions policies, to change the climate for diversity, to ensure that these medical schools, nursing schools, dental schools are welcoming to students of color. That was the focus of this report published by the National Academies. One of the, again, deeply honored that I had the opportunity to be study director for this report. This report was prepared to address what can health professions do to ensure that we are attracting and retaining talented kids of color. It called for changes in the health professions education admissions, things like whole file review, de-emphasizing standardized tests. And I'm so grateful to see that some medical schools, nursing schools, indeed some undergraduate institutions are beginning to de-emphasize things like standardized tests, which in my view are racially biased and have served simply as a barrier to people of color entering into higher education. We need to attend to the institutional racial climate. It's not enough to admit students and faculty of color, but if we have a hostile racial climate in these institutions, we are not going to accomplish our goal because people will simply leave those institutions. We need to include diversity efforts in our accreditation standards. No medical school, nursing school, dental school survives without accreditation. And so to the extent that our accrediting bodies can take greater steps toward rewarding diversity efforts that these institutions undertake, that will go a long way toward institutional transformation. And again, it will tackle institutional forms of racism that have historically kept out people of color from the health professions. And we have to reduce financial barriers to students seeking to work in underserved communities. We currently have the U.S. Public Health Service programs run by HRSA, other programs that essentially provide opportunities for young people to get training in a health profession's career. And in exchange, those young people are asked to serve in underserved communities, such as our Indian reservations or other communities to complete their payback agreements, to complete their service agreements. We need to radically expand these programs. It's my belief that a physician or a nurse or a dentist who seeks to work in a medically underserved community as their career should not have to pay a dime in tuition to get that training. We so desperately need those people. And again, all of this rests on promoting educational equity. So all of us, I believe, need to be engaged in the effort locally to fight for educational equity. And that starts with acknowledging the deep racialized inequities in school funding, as well as other barriers that young people of color have experienced. I want to leave you with a quote that I like from Dr. Mary Bassett, who was formerly the Commissioner of Health in New York City, is now at Harvard Medical School. Dr. Bassett wrote that anti-racism is a collective healing without which our nation will remain painfully and inequitably divided, corroding opportunity, spirits, and bodies alike. Our nation cannot afford to remain on this path. We cannot afford to allow racism to infect our healthcare systems and our society broadly. It takes too great a human toll, and it takes too great a toll on our whole society. And I believe we are starting to come to a reckoning with the deep toll of racism on our nation. I thank you so much for having me at this important conference. I congratulate the National Center on Primary Care for 25 years of leadership and innovation. And I look forward to seeing if we can take a question or two with the time that remains.
We absolutely can. And thank you so much. You really hit on so many of the themes and discussions that we heard throughout this 2 days. So that was really great. We have a question from the audience about the effect of the pandemic on the healthcare workforce. The question is, can you discuss the relationship between widespread burnout of the primary care healthcare workforce and strain on the healthcare system due to COVID, and the potential influence that this burnout and strain might have on health equity and disparities? And then what can we do to mitigate this?
Oh my gosh, such a wonderful question. Thank you for that. I want to start by just saying something about COVID and inequality. We've seen clearly that COVID has exposed deeply entrenched inequities and racism in the United States. But here's the thing, again, connecting this to the fates and fortune of all of us. The United States was disproportionately hurt by COVID in terms of mortality and infection rates. The United States just passed 1 million deaths as a result of COVID. We are disproportionately dying in the United States of COVID. And I believe one of the key drivers of this terrible statistic is inequality in our society. Inequality produces social division. It produces mistrust. It produces a poor allocation of resources to communities where it's needed. And unfortunately, we saw all of that happening in the United States during the COVID pandemic. And I believe that the United States suffered more than other nations because of our racism and our inequality, allowing COVID to spread. COVID as a virus loves social inequality. It loves social division. Because what it does is it produces a country where many are vulnerable and exposed while others struggle to ensure the safety of themselves and their families. With respect to providers, clearly, our frontline providers deserve incredible credit for their generosity of spirit, for their courage, for their endurance to provide care to populations in need. We know that Black and brown communities were disproportionately hurt by COVID, and no doubt many on this call are among the frontline providers that worked tirelessly during the pandemic to help provide healthcare to those in urgent need. In terms of burnout, clearly burnout is a significant issue in the provider population. I believe that providers need to be able to have the resources necessary for self-care, and that starts with good mental health care, good behavioral health care. But sadly, we have disinvested from the mental health care system in the United States. And in fact, we've learned that that mental distress as a result of the pandemic was widespread, but disproportionately hurt people of color who had fears about infection, fears about losing income, et cetera. And so our frontline providers had to deal with the brunt of that. We need to ensure that our providers have access to mental health services and other services that are necessary to restore our bodies, our minds, our spirits. And so here again, we have failed. We have failed our population generally, but particularly our healthcare providers who are attempting to work under extremely difficult conditions, sometimes without the supports necessary to ensure that they don't burn out. So I wish I had more to offer in the way of specific suggestions there, other than to say that we have to do better as a country. We have to ensure better access to mental health services, culturally competent services, and particularly to be aware of the needs of those on the front lines.
Absolutely. And I think, it's not been lost on this audience what you described and really highlighted as this 20 years since unequal treatment and how little progress has been made. But that really was the impetus for this event and the momentum that potentially we're feeling with the kind of unification of focus on equity. For the audience that has been, in this for 2 days and really thinking about, what is the call to action? What are your suggestions for people to really take that action from whatever position they are in their organization and their community?
Oh, absolutely. Thank you for asking that. So we need to, all of us, to be engaged in this work. And so part of it is political. We need to address the political determinants of health, which my friend, Professor Daniel Dawes, has been writing about and talking about. Many of the issues that I talked about in this talk are political determinants of health. These are policy decisions with respect to things like Medicaid expansion, whether or not we're going to address our deeply inequitable healthcare systems. And so physicians and healthcare professionals are often the ones who are actively listened to when policymakers are attempting to figure out where to go, what direction should we take to address these inequities. So I urge all of us to be actively engaged in the political arena. I'm not saying this to be partisan. What I'm saying is that we each have a responsibility to educate our policymakers and help them understand the deep toll of inequity and racism on all of our communities. So that's one. Second, we need to be engaged deeply in our communities. I mentioned that social distrust and a lack of social cohesion helped COVID to be much deadlier in the United States than in other countries. We can solve that at the local level by beginning to come together, our civic institutions, our faith institutions, our business leaders, recognizing that our fates are intertwined, as Dr. King said. We cannot allow division to continue to erode this nation. And by division, I mean racism in all its forms, sexism in all its forms, xenophobia, gender and sexual orientation discrimination, homophobia. All of these isms are in fact making us sick. We saw that during COVID, and we need to be talking to each other, to our civic institutions. We need to be working across sectors in our communities to ensure that there are opportunities to develop partnerships and collective action. It's clear that there's a lot that we can each individually do, educating folks in our communities, but also finding ways to build bridges across walls of distrust. I don't think I've ever seen a time when our nation harbored higher levels of distrust, fear, and anxiety about our direction politically and socially. It's up to all of us to show that we can overcome this deeply divisive period and overcome the voices of hate, fear, and bigotry that are truly eroding our nation.
Absolutely. And hopefully we have found some of that unification here around this issue Well, thank you so much. Really appreciate your time and the work that you have done over so many years.
Thank you very much. It's been a pleasure to be here.
Absolutely. Dr. Mack, handing it off to you for some closing remarks.
Thank you, Megan. Great way to sum up the event. Thank you, Dr. Smedley. Great job. Call to action to actively engage in the political arena, but also in your community. I just have a few comments, but I just want to make note. We're going to put an evaluation survey link in the chat. Please take a few minutes while I'm talking, which will be very brief, to tell us what you thought about the events and give us your feedback. That'll be most helpful. So we're at our end of our time together, and thank you so much for joining us on this journey. At the beginning of the event, we asked you to consider two questions. What is your role, my role, in the movement to achieve health equity? What can I do today to advance health equity within my sphere of influence, where you are and what the area where you influence? So I hope you've had a chance to think about that, find the answers, and we hope you can view us, the National Center for Primary Care, Morehouse School of Medicine, as a partner in this mission. So please reach out to us after this event. Let's partner on advancing health equity. This event, again, would not have been possible without generous support of the United Health Foundation, the Dr. George Russ Endowed Research Fund, and the National COVID-19 Resiliency Network as our major partners. We owe tremendous gratitude to them, but also to all our partners who helped in some way, who participated. Thank you. A huge thanks to, I don't want to get into name and name, but the NCPC event planning team, the great job that you all have done, and other members of the Morehouse School of Medicine who have participated, but I want to really thank the NCPC event planning team, each and every one of you. So thanks again on behalf of our host, Megan Douglas, the National Center for Primary Care, and myself. We want to thank you for sharing this journey. At some point, we want to put all this information online where you can access individually the talks, presentations, the comments that you heard here today. So it's been a great event. We thank you for taking the time. And this is the 25th year anniversary of the NCPC, so you'll be hearing more from us. Thank you. God bless.